So, welcome everyone to this post-lunch session. We've got the exciting presentations from our local colleagues now, uh, and we've got a series of really excellent presentations lined up for you. Just to ensure, we're going to be very strict with time, and if your presentation isn't finished in the time, then I'm afraid we're going to have to stop you because of the number of presentations and the length of the session. We're going to have to be quite strict with that. So thank you all for that. And John, if you would like to introduce the first presenter, please.
Yeah, thanks, Sonal. Hi, everybody. So our first group of presenters are actually trainees. We've got some trainees, AHPs and med students, which is great to see a good diversity of presenters through the afternoon. Our first presenter is actually joining us online. Just check Pedram is there. Pedram, are you there?
Yep, I'm here.
On the screen now.
Can you hear me? You should be able to see me.
Yeah, brilliant. I'll just introduce you, Pedram, and then you can kick off then. So I think Pedram will be known to many of you in the room as one of our trainees, and his presentation is on immune checkpoint inhibitor-related hepatotoxicity in Wales, a description of practice and platform for change. So 7 minutes and then 3 minutes for questions.
Okay.
All yours, Pedram.
All right, thank you. Okay, so you should be able to see my slides. So thank you for that introduction. I'm Pedram. I'm one of the gastro trainees, and my talk is on immunotherapy-induced hepatotoxicity in Wales, review for practice and platform for change. So I just want to get this out of the way. There we go. So immune checkpoint inhibitors encourage the immune system to destroy cancer cells, in short, and they can have the undesirable effect of autoimmunity, and 2 to 25% of cases develop hepatotoxicity. Management of this includes exclusion of alternate pathologies, cessation of immunotherapy, steroids, and in some cases immunosuppression. But our practice recommendations are largely based on consensus rather than robust data. So that leaves some ambiguity in the approach and management of these patients. So my project was looking at management of this condition in Wales using a clinician survey and a multi-centre retrospective analysis. We employed a collaborative approach with oncology from the beginning. And the clinician survey had 18 participants, equal gastro and onc, and the proportional distribution of these responses you can see in the map here. And we asked the questions pertaining to the areas of ambiguity: when to perform a liver biopsy, when to use second-line therapy, which agents preferred, and other general challenges. And in terms of indication for liver biopsy, generally speaking, that was steroid resistance. And the gastro and hepatology answers themed more towards excluding alternative pathology, whereas the oncology answers in this domain themed towards joint decision-making with hepatology. And now in terms of second-line immunosuppression, again, steroid refractory cases were the indication for this, but this included answers such as slow to respond, worsening LFTs on steroids, and steroid resistance. So there's some variation in answers there also. The choice of immunosuppression tended to be mycophenolate or tacrolimus preferred, with one hepatologist suggesting infliximab and one oncologist suggesting budesonide should be the second-line therapy. And there was lots of reasons for choosing between the two, including clinician preference and, clinical indication, but also monitoring purposes. Cholestatic cases were generally people were less experienced treating these. And amongst oncologists, answers were themed towards urgency and poorer prognosis in this cohort of patients. Whereas in hepatology, there was a bit more of a range, and there was less themes of urgency in the responses. And some people use ursodeoxycholic acid in this, but not everybody. Then we performed a retrospective analysis over a year, looking at the more severe cases across all cancer centres in Wales, and yielded 46 cases. Now, I'm not going to go through this slide, just demographic data, but just wanted to highlight that in the workup, 17% of cases underwent a liver biopsy of the patients we looked at. And most cases were hepatocellular, but 41% were cholestatic or mixed in terms of their LFT derangement. And then in terms of steroid induction, dose and choice was largely appropriate and based on guidelines that are available. And roughly 21% of cases in total were treated with immunosuppression. We look at comparing hepatocellular and cholestatic cases and looking at steroid duration, there wasn't much difference between the two groups, but you can see that there's a large number of patients who are on steroids for a long time. And we took 90 days as an arbitrary cutoff and saw that roughly 30% of cases were treated with steroids for more than 90 days. And if we look at how many patients in the end used immunosuppression, and I could just draw your eyes to the scatter plot in front of you. These were the cases that were treated with immunosuppression specifically. So there doesn't seem to be much correlation with steroid duration. And I should say that some of the cases that were on steroids for a long time did develop adrenocortical insufficiency. Some of them developed osteopenia. And I should also say that some of them were on low doses of steroids to facilitate rechallenging. So there was different reasons and different complications there. Looking at the steroid above 90 days cohort, only 25% of them were started on a steroid sparing agent. So our qualitative data identifies steroid resistant cases to be a challenge and a reason to escalate care. But we look at the retrospective data, and there's a large proportion of patients who are on steroids for a long time without steroid sparing agents and without histological assessment. And I think we can postulate lots of reasons as to why that might be, including, individual challenges with the patient, complex patients, other immune toxicities. But I think what we've got control of here is understanding the interspecialty working and the challenges in terms of acquiring hepatology advice and marrying up the two approaches. That's something that we could potentially work on. So what we want to do now is to establish a hepatology focus group, pool our ideas, and establish which elements of treating this condition can be generalized. We want to work closely with our oncology colleagues, see what we can learn from them and understand their approaches. Is there a difference in how we approach a patient on curative therapy versus palliative care therapy, for example? Should we be more aggressive? We don't know. And think about the areas that we can collect data collection in the future and zone in on, for example, steroid complications. I'd like to thank the rest of the team. I'm really grateful, when I couldn't have done this without them. I've sped through that. So thank you for your time, and I'd like to welcome any questions.
Thank you, Pedram, and well done for doing 6 minutes and 30. So well done, set the pace well. Let's open up for any questions. Dr. Hawthorne in the front row. Good to see you, Dr. Hawthorne. Let's coming your way now.
Red microphone. Hello, I'm Barney Hawthorne. I'm a gastroenterologist, but much more luminal. Tell me, what guidelines did you compare it to, and where the gaps in the guidelines, where some of the things are not covered adequately in the guidelines?
Yeah, so there's two guidelines that were referenced in the qualitative data. There's the ESMO guidelines, and there was the Clattenbridge, the Clattenbridge guidelines, but they were referenced. And as I said, it's not very prescriptive because there's not robust data. There's no detail on what to call steroid refractory, for example. And I think that's where some of the ambiguity lies, if that answers your question.
Thank you.
Yeah, please, Veen, behind you, Barney. Thanks. Veen?
Is there a difference between the way the steroids are managed between the hepatology team and the oncology? What I see normally in my practice is ALT increases from 50 to 60. The oncology team double the dose or increase the dose, whereas we would have watched.
It's a really difficult question to capture. And that's sort of one of the reasons for doing the qualitative component, to try and establish the different approaches between the specialities. But there's a lot more that you could go into from the qualitative data, which I didn't have necessarily time to do. But there is definitely some difference in approach. That answer to that question specifically is quite difficult to capture, but there is likely to be some different approaches based on prioritizing cancer therapy versus prioritizing ruling out alternative pathologies and the hepatology approach that we normally undertake.
Lovely presentation. Have you developed any teaching material for local oncology as well as gastroenterology trainee?
We haven't, but I suppose that could be an outcome or a change that we could perform, and certainly that would but it's difficult to know what exactly to teach, I think, is the main problem, because what we need to do really is to establish some idea of consensus based on the expertise that we have, and we have a lot of expertise amongst our hepatology and oncology colleagues.
Right, thank you, Pedro. I'm going to draw that to a close. Thank you ever so much.
Okay, thank you.
And thank you for questions. Well, good to keep the questions nice and brief. So thank you, everybody. Hand over to Sunil.
Thank you, John. Our next presenter is going to talk to us about root cause analysis of post-endoscopy upper GI cancer, PUGIC insights from the all-Welsh cohort, and that's Dr. Simona Serish.
So I'll be talking about our findings from our all-Welsh root cause analysis of post-endoscopy upper GI cancers, which is a collaborative project across all health boards in Wales. PUGIC means cancer which is missed in a prior endoscopy, which was done within 6 to 36 months' time, which is a key cause of delayed treatment and worse outcomes. For illustration, just a case, 60-year-old gentleman with the previous history of perforated gastric ulcer, which was surgically repaired. OGD was done in February 2023, and it was done as a relook OGD. No cancer was detected at this stage. Another picture from the same test. By June, the patient had 2 admissions between 2 scopes: persistent weight loss, iron deficiency anemia, which are the red flag symptoms for GI malignancy. As you will see in the video, on the second endoscopy, he was subsequently diagnosed with cancer. Which is PUGIC. So first of all, I would like to thank all my team, all the registrars from Wing and the consultants across Wales. Because of their collaboration and efforts, we were able to do this. So we reviewed all upper GI cancers diagnosed across Wales from 2021 to 2024. Each case was screened for any prior endoscopy to see if it met the criteria for PUGIC. We ensured the consistency by using a structured RCA data collection tool. Across Wales, 79 cases of PUGIC were found between 2021 to 2024. This came from over 1,500 OGDs with upper GI cancers over this period. The rate varies between 3.5 to 6.3, with peaks in Battersea and Cardiff. PUGIC cases are spread across different anatomical sites. However, there are certain areas which were more commonly missed, highlighting high-risk sites like esophagus. Cases were found to be more common in the deprived areas, which reinforces the role of inequality in cancer outcome. Many of the cases were potentially avoidable. By learning from Puget cases, we can improve detection, reduce delays, and deliver better outcome. I'll encourage you to join us in November as we translate these insights into practical steps for improving endoscopy. Thank you.
That seemed to be a super fast express presentation, but we've got some questions in the front here. If we can have the mic, please.
I'm just trying to stick to the time.
Good. Yeah. Your data for Betsy only had Bangor. What happened to our other two sites?
From North Wales.
Yeah.
So there are still some health boards which are collecting data, for example, Narren Bevan, and we haven't got data other than Betsy yet.
No, Betsy, there's two hospitals you're missing. You've only put Gwynedd, Bangor Hospital.
Okay. Are there two there? Yeah.
Okay.
Yeah.
Is that just because there wasn't a reg to do it? Okay, we'll get Eugene.
Just encourage you to just for people online, if you're
Eugene to do
if you're asking
for
if you're
us. Yeah.
On literature quotes between 10 to 15% Puget's. And the last Scottish study which was published was 13%. Our rates are less than 7%,
Yes.
which is less than half of what is quoted.
Yeah.
Are we better at doing this or still not good?
According to the rates which we have got, looks like we are better. Yeah.
I'd
We can say.
probably wonder if we should be cautious before you have a complete data set.
Yes. Yes.
Interim data is always a little bit.
Yeah.
Yeah, my comment was exactly that. I think when we looked at Puget data, unless your surveillance weights are exactly in target, a lot of these surveillance cases still aren't being done. So you need to really look at all the data before you come.
Yeah.
Rodri?
For the Puget's you found in each site, have you given appropriate individual feedback or are there appropriate mortality reviews for them?
Sorry.
So for each of the Puget's that you identified, was as part of the study, was there any kind of root cause analysis or feedback to the individual endoscopies who missed those cancers? It's all very well presenting Puget rates. That's fine, but it needs to be a learning point at that point and get better and gradually reduce our rates. So what was as part of the data collection? Have you put any systems in place to enable some feedback?
So we are going to do upper GI quality improvement network meetings in which we will be discussing Puget cases and try to feed back to the services. And then it's an ongoing process and there will be more data analysis around categorization of Puget and how we can avoid, and it will be fed back to the services.
Can I just add to that, if that's all right, Rodri? So there's an external group validating all of these Puget's as well. Obviously, there's great effort put in by the registrar cohort to make sure that this is as consistent as possible. But there'll be pathologists like Adam sitting in front of me. There'll be, the team from Nigel Trudgill's group and so on that will look at these cases to make sure that firstly, we identify they truly are Puget's, and secondly, then we identify whether that's an administrative problem, an endoscopist problem, or whatever, and then that tailored individual feedback will be given back, hopefully.
Yeah.
It's a comment more than a question, really. But interestingly, the case you presented, I would say, is a fault on the surgical side because we should have biopsied it at the time of the perforation rather than a missed. And I wonder whether it's quite rare to have perforated ulcers, benign ones now, not massive, not definitely, but rarer than it was. But if they're perforated cancers, then gastric, we should always be biopsying them at the time. So I don't know if any of yours have been to surgery before they'd had endoscopies like the actual case that you presented, but yeah, just as a comment more than anything.
Yeah, I don't think it was reported as a cancer from the surgical side. And when the relook was done, they were looking for the suture site, and there was a lot of food and remaining debris and everything there. It could have been there.
And any perforated gastric ulcer should be biopsied at the time
Should
of
be,
surgery.
yeah.
Because
Agree.
it's a cancer until you prove it's not.
Yes, agree.
Any other questions online? I can't see any hands online.
I've got one quick thing. Your esophageal cases, I think in Nigel Trudgell's series, there was a disproportionately high rate of squamous cell cancers that have been missed. Is that what you found as well? Because we don't see, actually, we don't look, but we don't see as many of those, do we? But I think it was a very high rate, wasn't that right?
There were many. Yeah. There were.
Well, your case
I
with
can't-
squamous as
I
well.
can't quote the number, but as far as I know, not from Cardiff, but from other health boards, we have seen squamous cancers. Yeah.
Fires.
Quality of the endoscopy, because it is about how good the
Yes.
images are and the use of simethicone and
Yes.
even MBI, especially for these esophageal ones.
That is all in our data collection tool, mucosal cleaning, and if they have used any advanced imaging techniques to identify it, that is all. However, we haven't yet analyzed data completely, and that's all in the root causes. Yeah.
Okay, thank you very much. If there are no further questions. Sure.
Right, can I welcome up Ahmed Farouk? Ahmed, hiya. We're looking forward to hear your presentation. It sounds interesting. So this is going to be the biliary complications of chronic ketamine use. Insights from a case series.
Yeah.
What are yours?
Good afternoon. I'm Ahmed Farouk. I'm one of the senior clinical fellows working in South Wales region. I've got an interesting case series of secondary sclerosing cholangitis to present today. So we were asked as part of a gastro team to come and review a gentleman with worsening LFTs in ITU. It was a 22-year-old gentleman who had come in with overdose of ketamine in a dissociative state and was complaining of some abdominal pain and oliguria. He had significant past medical history of having a single kidney and cocaine-induced MI. Other than ketamine, he was also taking significant amounts of alcohol consumption and smoking as well. As part of the initial admission assessment, the examination was mostly unremarkable other than mild epigastric tenderness. So for further events, he had some bloods which were significantly deranged, most of which was this creatinine of more than 1,000 and some raised ALP and ALT with a normal bilirubin. He was initially treated by the renal team for a prerenal AKI, which improved, but he continued to get septic and went into septic shock, prompting an ITU admission. He had an ultrasound EKUB, which showed right-sided hydronephrosis with a loss of corticomedullary differentiation. During his ITU stay, he had some melena and had an OGD, which revealed severe esophagitis, but there were no signs of portal hypertension. As a context, he had a prior to admission, a CT scan with the urology team, which showed significant urinary tract pathologies, including ureteric strictures and bladder wall thickening, and which raised the question from the radiologist whether the patient is taking ketamine in overdoses for a longer time. So when we came to review the patient, he had significant derangement of the LFTs with bilirubin high of more than 300 and ALP high of more than 2,500. We did a non-invasive liver screen, which was completely normal, and the CT abdopelvis was performed, which showed normal hepatobiliary system with mild splenomegaly and urinary findings similar to the prior CT. So we moved on to doing an MRCP to further investigate this cholestatic jaundice, which showed these following findings. As you can see in the images, there is a lot of intrahepatic biliary duct dilation with multifocal stricturing and ballooning and central pruning, and dilation of the common hepatic duct with a normal CBD, and with the features which were suggestive of sclerosing cholangitis as per the radiology report. So we did a lot of literature research, and given the patient's presentation and lack of any IBD features, we made a careful diagnosis of ketamine-induced cholangiopathy in this patient. And the management revolved mostly around complete cessation with aggressive counseling, detox programs, and social support. The patient developed some intractable pruritus, which was dealt with ursodeoxycholic acid, cholestyramine, and antihistamines. Patient was then discharged and followed up in hematology clinic regularly with falling bloods and LFTs, which started to improve with the cessation of ketamine. So talking about this case in the last 12 months, we have had quite a few other cases with similar presentations, mostly young males with deranged LFTs and similar sort of MRCP findings. But there were some unifying features in all of these patients that they had abdominal pain and urinary symptoms and had an AKI in presentation. Their CT scans showed similar finding in the urinary tract as this first patient. 3 of these patients also had multiple admissions and complications with sepsis, including which led to prolonged ITU stay. So talking a little bit about ketamine, it's an NMDA receptor antagonist used mostly medically for anesthetic purposes, but recreationally it is known in the streets with names like Special K and KET, and mostly taken intranasally and causes a sense of euphoria, hallucinations, and increased libido. It causes a state called K-hole, which is like a detachment from the environment, resulting in an inability to respond to surroundings and move one's body functionally. It is extensively metabolized in the liver with N-methylation and dehydroxylation, and primarily excreted in the kidneys and the bile. That is where we see most of the complications from long-term ketamine use. The half-life is about 2.5 to 3 hours, and the high from ketamine usually lasts about 30 to 45 minutes, depending on various factors. So the exact mechanism of ketamine cholangiopathy is unknown, but there are quite a few factors which contribute, like having toxic effects on the cholangiocytes, leading to inflammation, fibrosis, and eventual stricturing of the biliary system. It can affect the smooth muscle tone, causing the spasm of the sphincter of Oddi, leading to biliary stasis and ductal injury, and it can also cause vasoconstriction and ischemic cholangiopathy from that. It can also cause an inflammatory and autoimmune sort of a reaction, which is similar to a PSC. So there's been a lot of coverage and noise in the news and media about rising use of ketamine, especially in the younger population, and a lot of deaths related to it, especially in the South Wales region. So other than the causes that we have talked about, it can cause a lot of problems with memory impairment and renal derangement. And there can be some other GI issues like abdominal cramps, which are in other words called K cramps. And the patients usually tend to take more and more ketamine to resolve their systems, which causes sort of a vicious reaction of having further complications from it. And we've seen in the last 10 years, there's been an exponential increase in the deaths from ketamine usage, going from about 15 deaths in 2014 to 197 in 2024. So to summarize all the cases that we've discussed about, ketamine can be one of the leading causes in people who have been using it for a long time to cause deranged liver function tests in sort of a cholestatic picture. And we should always consider it as a differential, especially when there's a lack of IBD features in patients, because it can very easily be confused with the PSC, given that findings are similar on MRCP, and a specific question should be asked in case of someone with a suspected PSC. So due to lack of extensive research and studies, there's quite a few unanswered questions regarding this, but the take-home message should be, think ketamine. Any questions? Thank you.
Yeah, any questions?
Yeah, so most of these cases that we had were using ketamine for quite a few years when they were referred mostly either through detox programs or through their GPs on regular monitoring when they had started to develop abnormal LFTs. Usually when they had clinical symptoms, it was usually at a very advanced stage. So we were unsure how long the process was going on for. So we didn't encounter any of those patients who had ketamine used for medical purposes. All of these cases that we had received were from Southwest Wales region who were using it recreationally for quite a few years before they ended up in the hospitals with us.
In UK, they don't use ketamine as much. whereas in Europe and Asia, they use ketamine a lot. And it has been highly publicized during COVID epidemic. There are lots of papers where ketamine was used sedation, and it has got strictures where use was prolonged. So especially the duration was more than a week to months when they had to sedate them. They have found them there.
Can I just ask a quick question, Ahmed? Really good presentation. Just a question. Obviously, there can be a little bit of diagnostic dilemma, as you sort of said, a bit of overlap, especially with autoimmune cholangiopathy. In those cases, obviously, we're looking at the history of whether or not there's significant ketamine use. Sometimes we don't always know the extent of these patients. Did you look into whether or not there was any? So obviously, in this case, you didn't biopsy, but in cases, is there any sort of histological features that would delineate between ketamine-induced cholangiopathy and other causes?
Nothing that we could find out from the literature search as we did, and we did a reading into the BSG guidelines as well, and the guidelines also say that they've done some retrospective studies in patients who were found to have PSC, and they showed little to no difference in terms of differentiating whether it could be from the ketamine use or whether it was primary sclerosing cholangitis.
We've reached our time. Sorry, Patrick. You'll have to ask him afterwards. Thank you, Ahmed. Thank you.
Thank you very much.
Thank you. And our next presentation is titled Wellbeing Education in Doctors Does It Matter? A Quality Improvement Project. And we have three presenters. If we could ask all three to come to the podium, and so that there's no time lost. And our presenters are Doctors Timea Raven-Gregg, Trevor Pinchman, and Charlotte Evans. So over to you.
Thank you. My name's Charlotte. I'm one of the F2s. I'm in Swansea at the moment, and I'm here with my colleagues, Dr. Timea and Dr. Trevor as well. We're all part of a charity called Medics in Mind, where we're hoping to improve the mental well-being of doctors. So essentially just talking a little bit about a pilot that we've done at our hospital in Morriston. So firstly, why is wellbeing important? So we have a mental health crisis amongst doctors in the UK. So the suicide rate amongst doctors is 24% higher than the national average. There seems to be a desire for sort of doctors wanting some wellbeing support. There's just not really the resources available, essentially. So when we talk about mindfulness, I know you've had some talks on this already, but just kind of a little recap, is the awareness and non-judgmental acceptance of moment-to-moment experiences. So it's kind of being aware of the emotions and feelings that you're experiencing in that moment, what might be influencing that, and what can you do about that as well. So my colleague here, Timmy, will be talking a little about who we are as a charity and what we're doing.
So essentially, we are a charity called Medics in Mind, and our mission is basically to promote mindfulness amongst doctors and to allow doctors to open up and feel vulnerable to talk about their experience. And so through this charity, we hosted a wellbeing fair in Morriston Hospital in January to assess sort of the understanding of wellbeing and mindfulness and how we could improve this in the hospital locally. So our aims were to establish the understanding of mindfulness and its benefits, to determine doctors' likeliness to use mindfulness during stressful situations, and to evaluate doctors' familiarity with mindfulness techniques. And Charlotte kindly created this flyer, which we distributed around the hospital to try and get people to come along to it. So in terms of our method, so we designed a wellbeing fair, which was our intervention. We then had a questionnaire, which we circulated to 17 participants, both before and after the intervention. And this collected basic data on demographics of the people that attended, and also questions regarding burnout and stress at work. But we were most interested, obviously, in what people thought about mindfulness and what their pre-existing knowledge of this was. And then in terms of our data interpretation, we then used a student t-test with assumed equal variance to compare the before and after answers to the questions. So these were the ones that we were most interested in. So this was, how would you rate your knowledge of mindfulness and meditation techniques? And we had a 5-point Likert scale. And we gave this question before and after in the questionnaire. And then the same with these ones. So questions 4 and 5 were how likely doctors were to practice mindfulness and how important did they feel it was for doctors. So I'm just going to hand you over to Trevor now to talk about the results in a bit more detail.
So as can be seen from our pre and post interventional studies, you had approximately 6% of people pre-test that answered that they would strongly agree with the statement that they actually had good knowledge of mindfulness. When you then, after our implementation, this went up to 88% after, which again represents a statistical significant shift in the perception of knowledge, both before and after. You can see this will be a common trend throughout these results. The next question that we asked was, I am likely to practice mindfulness or meditate when I experience stress in the workplace. Again, 6% in our pre-questionnaire answered that they strongly agreed with this message, and 24% said that they just agreed. After implementation, however, this went to 100% of participants were likely to practice this. The breakdown being 35% is strongly agreeing and 65% just agreeing. Again, when taking a look at this and running a t-test on it, statistically significant data, clear directional shift, going to p being less than 0.001. And then the final question we asked was, how important do you feel mindfulness is for doctors? Again, the same theme. So before the test, before the implementation, you had 41% strongly agreeing and 18% agreeing. Again, clear directional shift, 88% agreed after 1 hour of teaching, with the further 12% just agreeing. And just for ease, just to make sure that everyone is aware of this, as you can see, the directional shift, again, clear statistically significant data, both before and after. And I'll just pass over to Timea to conclude.
So in conclusion, we count our programme as a success. So we had a meditation session kindly led by Dr. Dave. We had some informal chats about worries and struggles and fears of doctors. And then we also did a journaling session. So this kind of thing that we put together was obviously very helpful for people. It increased doctors' knowledge and awareness of mindfulness techniques, which is the sort of message that we wanted to get out there. However, we do recognise that this correlation that we found may not actually equals causation, in that it may increase mindfulness practice, which hopefully in turn will reduce stress and burnout, but we can't guarantee that that will definitely happen, especially with other workplace variables that are not in our individual control. We obviously appreciate there's an element of selection bias, so the people that came were the more willing to turn up, and so we might not be reaching those that actually might need help with regards to this type of thing. So in terms of our future work, we hope to explore the long-term effects. So we'd probably like to do another programme like this again, and then try and reevaluate effects at sort of 60, 90 and 120 days post-intervention to see if we've actually had a long-lasting impact. So yeah, I'd like to thank Dr. Dave for his help with our programme, and also would like to welcome any questions.
You. That's excellent. Can I just ask, while others are thinking of questions, what was the total number of responses you had? Because I perhaps missed that.
We had 17 people turn up. We tried really hard to sort of outreach to people with the QR code, word of mouth, to various different wards and departments. But it was quite difficult to kind of pin people down for that session that we had. So yeah, we were happy with the number that came. I think for a first event, we were quite pleased. But obviously, ideally, we'd like to reach to more people. But with doctors having such limited time and stuff, it's very difficult. And that's definitely a big barrier to some of our work.
What were the total number of survey responses?
So it was 17.
Okay.
Yeah, so 17 people came, and well, we didn't exactly force them to do the survey, but it was highly suggested that they did it so that we could evaluate how beneficial it was. So yeah, it wasn't mandatory as a sense, but we did sort of say, look, this is the QR code, please fill it out if that's okay.
No lunch unless you fill the survey in. Yes.
There's some questions here.
Oh. So obviously that required the group of people to turn up to the session. How would you sort of develop that wider for busy, burnt out people that may not have an hour to pop and do their mindfulness?
Yeah, it's really difficult. I think ourselves being doctors, it's very hard. I would probably ideally like to find some spare time in which I can make this more accessible to people and perhaps actually go to them rather than have them come to us. So ideally it would be looking at kind of like expanding our team and then trying to like go and outreach towards, but even then, like people that are very busy that might need this are going to find it difficult to take the time out to practice mindfulness. So it's trying to like get to the people that need it most, which would definitely involve some type of outreach kind of service, which is hard for three of us, but it's doable in the future, hopefully.
One last question.
I think work that you have been doing is really inspiring, but onus shouldn't be on you. So have you approached the head of surgical school and sort of educational supervisors or the health board education leads to help you, because you are doing your own job and doing this extra?
We've definitely had chats with the Wales Foundation programme about this, and you guys also met with occupational health in Swansea Bay in particular, about being sort of a kind of in between for people to come to us and then occupational health formally if they needed that. So we have set up some connections there. I think the big barrier with these types of things is funding and that type of thing, which is a different kind of conversation. But we've definitely tried to make some connections and hopefully we can establish those a bit more and get something going. Yeah, of course.
And the other important thing is before we do that, we needed data to actually back up that what we were doing and are doing is actually working. And that was the whole purpose of this pilot study. We now have the data that does prove that just 1 hour of intervention does actually statistically change people's views on the subject matter. So it does give us more onus to go to people and go, what we're doing does work. And that's hopefully what we'll take forward in the future. Thank you.
Thank you.
Great, thank you very much. Very much in the theme of our last couple of days, well-being. Thank you. So can I invite up Isabel? You're there. Hello, couldn't see where you were. Hi, Izzy. Hi. So Isabel Phillips is going to present to us on the introduction of serum ELF testing for assessment of liver disease. It's cost-saving and speeds up the diagnostic pathway. All yours.
Quite a mouthful, that, isn't it? So I'm going to talk to you about a little bit of work we've been doing in an Iron Bevan. Not quite as fashionable as mindfulness, but more important to our execs than doctors' well-being is saving time and money. So just to set the scene for I'm going to imagine this is bread and butter to most of you, but essentially, historically, we did a liver biopsy to diagnose advanced fibrosis, and more recently, we are stepping more towards FibroScan is the mainstay now. And FibroScan does have its limitations. Generally, we get failed readings about 10%, and that can be in patients who have really high BMIs, patients who have heart failure, patients who can't get to these scans, for example. And we need more tools in this toolbox, essentially. And that's where the ELF test comes in. Now, there are no pictures of elves in these slides, which is a bit of an oversight, I think. So what is the ELF test? So the ELF test is actually just a serum blood sample. And what you do, you send off a yellow top bottle and it measures these 3 biomarkers, which we know are elevated in advanced fibrosis. I'm not going to try and read them out for you. And essentially what you get back is not a figure of the biomarker level, but you get a score. And this is what Siemens, who make the test, give you as a way of interpreting it. And essentially what we can then do is assess how at risk somebody is of advanced fibrosis based on their ELF score. Anybody who comes back as less than 9.8, that's got a 95% negative predictive value for advanced fibrosis. So they are less at risk, essentially. So what are we currently doing with ELF? And I'd be really interested at the end to get some feedback from you guys on how other people are using it. So in England, when you look at it, primary care in some places have access to ELF. Okay, so local liver centres send their primary care colleagues advice on who to do the tests in, how to interpret it, who to refer to secondary care. But in Wales, that's not how we're doing things at the moment. So you're probably all familiar with the All Wales Liver Pathway, and that's how we do things, primary care referral to secondary care in Wales. And at the moment, we're not aware of anybody using ELF, or particularly not regularly, and nobody in primary care. So what we're currently doing in ABB, so the GP sends some bloods and you get an elevated ALT. That generates in the lab an automatic reflex of an AST-ALT ratio. And if that comes back as over 1, the GP is advised to refer for a FibroScan. Now, we're doing 2,500 of these a year in an iron bevan, which is quite a lot, isn't it? Particularly if you consider we're saying 1 in 10, it's not interpretable, okay? Or you don't get a figure in some of these patients. So what do you do then? These are the ones we get a little bit stuck. So this is where ELF comes in. So we started using ELF last summer when we got the funding for it. And between last June and March this year, we've done 75 ELF tests. Now, they are not cheap. They're £60 a test. So our spend is £4,500 on these already. Sounds like a lot for a blood test, doesn't it? When we've done these, so either 44% are a first fibrosis test, and then 43% of these are when we've done a FibroScan and the result is essentially indeterminate. So either they've got features of portal hypertension, but the FibroScan doesn't suggest cirrhosis, or when the number isn't quite fitting with the clinical picture. Only 2 of these 75 have had a liver biopsy. So why do we think this works then? So ELF is faster. So when we look back at this, from decision to do a biopsy to results going to patient, about 12 weeks. ELF, you send the blood sample and you've got a result on your desk, in theory, within 2 to 4 weeks. Okay, so it is much quicker. It's less invasive. So if you really crude figures, we've prevented 73 liver biopsies, and patients generally prefer to be stabbed in arm than stabbed in liver, is what we've established in the last year. The cost of a biopsy, these figures are quite hard to get hold of, but we've been suggested that if you're not including the time in recovery, a liver biopsy costs about over £500. So we've saved a lot of money just in the biopsies that we haven't then done. It's freeing up clinic space. So in 44 of these patients, ELF alone has excluded cirrhosis. So they don't need 6 monthly ultrasounds. They don't need 6 monthly clinic follow-up. That's also saved a lot of money. So these figures on here are from England. We haven't actually got them for Wales, but if you're looking at about £100 a clinic appointment, £50 an ultrasound, that's another huge saving just by not, by using ELF instead in these patients. So very crude maths. This is 9 months worth. If we extrapolate, it's over £50,000 worth of saving over a 12-month period just by using ELF instead. So essentially, in conclusion, we think, we haven't quite explored yet how we can actually be using ELF in Wales and how we could be doing more with it. But we know just from this simple data, we're doing less liver biopsies, which is preferable for the patients and for us. It's cheaper, it's saving money, and it's faster. And in an iron bevan, literally in over a year, we're looking at £50,000 worth of money, which is really pleasing for our execs. So any questions on any of that? Be interested to hear if anyone else is using them actually.
Thanks, and thanks again for keeping the presentations really snappy and brief. So thanks, Isabel. Can I just ask you one thing? You might have said it, but is this an investigation that only certain people can request?
It's a very good question. So at the moment, the way we're doing it in an iron bevan, only a consultant hepatologist can request it. A registrar under the name of the consultant can request it, but it is exclusively a hepatology test at present. In England, the GPs can do it.
Let's go first with Rodri at the back. Rodri Stacey at the back, not the other Rodri at the front, Rodri at the back.
Less important, Rodri, I know. What's your thoughts on GPs getting access to it? Because we have other tests that, we're having a stream of, for example, patients with reflux symptoms, but their fit is positive.
Yeah.
I'm sure we all have the same experience in the room. What's your thoughts on expanding specialist testing to primary care, pros and cons?
So we talked about this at length within the health board, because when you look at something like this and you're trying to assess how other people are using it, if you put this into Google, you get primary care guidelines from places in England where they're just telling GPs how to do it. So thinking, how have we got a test that only a consultant hepatologist can do in Wales, and a GP can order off their own, or GP registrar can order off their own back in England? So in England, there's obviously a large push to keep things in primary care, which we haven't seen so much in Wales at the moment. And I think even in England where they're doing them, they are strictly on the, the guidance and the advice of a hepatologist or a liver centre. So whether they get weird and wacky stuff, I imagine they do. But I think as long as it's advised by a specialist who knows how to interpret the test, it's probably okay.
I think, Patrick, do you want to ask a question? I'd have cut you off last time. I feel very guilty, so I'm going to have to let you.
He's
give the
going to
floor.
heckle me, so cut him
Yeah,
off.
no, that's why I wanted to get him in. Yeah, go on, Patrick. Go for it.
£60 for an ELF test is probably cheaper than the FibroScan when you take into account patients travelling, the environmental impact, the nurse's time in clinic. Will is FibroScan no longer needed?
We don't know, and there's not actually a lot of evidence at the moment supporting ELF on its own. So there is a huge trial going on at the moment that looks at the various ways we assess for advanced fibrosis, so the scoring systems, FibroScans, and ELF proceed into biopsy, that will then look at them, whether they should be used in combination, whether they should be used individually. But the current BSG advice on that is that ELF should only be used as an adjunct to, say, in primary care, a FIB4 score that's a little bit squiffy. So at the moment, there's no suggestion we're moving away from FibroScan, but I would say watch this space.
Final ELF-related question from Dr. Dave in the front.
I'm not very aware of current guideline, but what do you suggest? Is that similar to Patrick, do the FIB ultrasound and only for the people who FibroScan and only people where we can't interpret FibroScan we do this, or what will be the sequence?
So in Wales, primary care don't tend to do a FIB4. We use the All Wales Liver Pathway. I'm sure some of them do them, but that's our pathway here. Is you go high ALT-AST ratio, refer for FibroScan. And at the moment, we're only using them generally for the ones where the FibroScan is not interpretable. But we have had cases since we've introduced this for, say, patients who can't get to appointments, or if we're trying to rule out cirrhosis, we've had a patient with complex mental health issues that trying to get from FibroScans, routine ultrasounds when we weren't sure if the patient was cirrhotic. So I think how it's used is probably at the moment very dependent on user. And I think moving forward, we'll probably get more clear guidance on how we use it.
Thank you very much. Thank you.
Our next section now are presentations from the AHP category, and we've got our first presenter, Adam Nixon, who's going to be talking about prioritizing colonoscopy, impact of a novel liquid biopsy blood test on PROMs and PREMs in surveillance colonoscopy. Adam.
Hiya. So I'm Adam Nixon, and today I'm giving you this presentation all about liquid biopsies, surveillance colonoscopies, PREMs and PROMs. I'm going to start with a little bit of audience participation. Please can I get a raise of hands, anyone who has heard of a FIT test? I was expecting as much. For those of you that didn't raise your hands, a FIT test stands for a fecal-immunochemical test. This is the test that you'll be given by your doctor if you go to them with symptoms of bowel cancer. Now, the thing with a FIT test is it's bloody shit. By that, of course, I mean it tests how much blood there is in your stool. If there is more than 10 micrograms of hemoglobin per gram of feces, you will be referred for a colonoscopy. There's a huge backlog of patients waiting for a colonoscopy, and you can see them here split apart by the different categories of patients. The important thing to note is this big orange group in the middle are what are known as surveillance patients. These are patients that a doctor has said is at higher risk of having bowel cancer and thus should have colonoscopies to check. This includes patients that have previously had bowel cancer, those that have had multiple polyps, those with family history, a genetic risk, or conditions like IBD. So, who are we and how can we help? I work for a company called CanSense. We are developing a blood test for bowel cancer. For surveillance patients, it is not recommended by the BSG for them to have a FIT test. As such, currently all of them are just sent straight for colonoscopy. With our blood test, we take your blood, spin it down to the serum part of that, scan it using Raman spectroscopy, give that to our machine learning model, which will then determine if you're at higher or lower risk of having bowel cancer. We've conducted a study to look at surveillance patients that are overdue for colonoscopies and measuring patient experience as well, using PREMS and PROMS. And we ask the patients how they feel about both PROMS and the CanSense blood test being used to determine waiting list prioritization. The definition for PREMS and PROMS is up there, but in simpler terms, PROMS is how a patient feels about how their health currently is, and PREMS is how a patient feels about the experience of the healthcare they've been given. These are the PROMS and PREMS we've done. The EQ5D5L is a generic healthcare-related quality of life test. The Cancer Worry Scale is, as the name suggests, and the PROMIS 4A is to test for depression and anxiety as it relates to healthcare. For our PREMS, we are asking about the acceptability of both PROMS and the CanSense blood test in the use of colonoscopy prioritization. So, this is our methodology. See who they are, recruit them, give them PROMS, give them a blood test, give them a colonoscopy, give them the follow-on PREMS and PROMS. This is how we did. Recruited 291, sent out their PROMS. We got an 82.8% compliance for our blood test, which we're very proud of. For the colonoscopies, they found 2 cases of bowel cancer, unfortunately, and 120 pre-malignant polyps. And then for the follow-up PREMS and PROMS, there was an above 75% compliance, which is above our target. This is the patient population we were able to record the data for. There are the 5 main groups. To explain the table on the right more simply, for those with a family history, these were our most resilient group with minimal psychological burden. For those with IBD, we would suggest ongoing psychological support to help with their ongoing disease burden. Those in the genetic group had heightened anxiety from their hereditary risk, which targeted counseling could help. Those that previously had colorectal cancer knew what they were getting into, and they handled the procedures well. And the polyp surveillance group were our lowest anxiety group, needing minimal psychological support. For our PREMS, it seems patients are really happy to have things help prioritize when they should get a colonoscopy, both having PROMS prioritize this and also the CanSense blood test. Though I do like to point out, they're happier with the CanSense blood test. How did that test do? Pretty well. We got a negative predictive rate of 99.3% and false positive rate of just 33%. As stated previously, only 2 of the patients that we surveyed had bowel cancer. As such, we aren't able to talk on the sensitivity of our model, though previously we have shown 90%. Extrapolating this result, this could lead to a 66.6% reduction in colonoscopy need for surveillance patients. In conclusions, we think a larger validation study would be beneficial, again, to look at that sensitivity and to confirm that carries on in this patient group. The PROMS did vary group to group, and the colonoscopies did help show some improvements. And we are currently working on economic analysis, and it's showing beneficial results, though that is still yet to come out. Finally, there seems to be a large audience for liquid biopsies to help prioritize colonoscopies. Thank you very much.
Thank you very much. While people are gathering their thoughts, can I ask you, that false positive rate is about the same as FIT, isn't it? And the negative predictive value, there doesn't seem to be a huge difference in terms of performance.
As I stated in the thing, the BSG does not recommend FIT for this patient group. As such, they currently have no test they can use.
Okay, thank you. Questions? Audrey?
Sure.
What's your thoughts on how we could use technology like this best? Is it to try and avoid a colonoscopy altogether for patients, or do you think it would be better for patients that need a colonoscopy but are facing unacceptable waits, as many of our patients are, to try and pick out the ones that are really at risk and get them done sooner? Where do you think the most effective use would be here?
Well, I think our priority is looking at that backlog of patients, as the longer that they are waiting, the more cancers that we miss. I do think there is a place for this in the healthcare pathways, but the backlog does need to be our priority.
Perhaps one more question. You had several groups of patients you spoke about. What was the difference between those with a family history and those with genetic risk? How did you define them?
So that would be those who had a genetic condition such as Lynch syndrome versus someone whose dad happened to have it.
So undefined family history rather than specifically first or second degree relatives and no mutation detected.
I don't know that specific, sorry. Thank you.
Okay, thank you. Thank you very much.
Thank you.
So our next speaker is David Jackson. Hi, David. Come on up. So David's going to talk to us on the governance through digital innovation, streamlining the Swansea IBD advice service. Thank you, David.
So yeah, good afternoon, everyone, and thank you very much for having me. I'm David Jackson. I'm a gastropharmacist, and within the past year, I've been specialising within the IBD field. And I'd like to tell you about how we've enhanced our governance of our advice line and taken some steps towards streamlining it as well. So when I joined the IBD team a year ago, I asked my nurse colleagues, what is the worst bit about your job? And they all categorically said the advice line, or the hell line, as some of them like to call it. How many calls do you get? 30 calls a day, loads. And what are the calls about? Everything, David. And where do you record your calls? And that was the only question that was met with silence. So some of these, when a patient was calling in, their name would be recorded on a notepad, and then a tick would be put through that name once that call is dealt with. If it met a kind of threshold of importance, then a note would be left on that patient's electronic clinical record. So how do we make this better? Where do we start? So the first thing was to make this paper-based system digital and then collect the right data. So I was guilty of the fact that I wanted the nurses ideally to collect 15 fields of data. They laughed, completely unrealistic. So met with them, we picked out what is the most pertinent, useful bits of information to collect, and we got agreement as a team. So this is a truly collaborative project. The other thing I noticed is that there's no auditable standards around the IBD advice line regarding volume of calls, types of calls, or even staffing ratios. So this gives us an opportunity to create our own benchmarks. And this is what our data collection performer looks like, which is an Excel spreadsheet, but I'd like to show you how it goes a lot further than that. So we collect the date of the call handler, the patient initials and NHS, which I've obviously cut out this slide, the person calling, whether it's the patient, family member, GP, another member of staff, their IBD diagnosis, the theme of the call, and then the call outcome, which is a free type box. And as this database expands, the power of the automation functionality increases. So it will bring back the previous call so we can review previous decisions and review those, or see if we want to go along that line or a change in tact is needed. Number of times that patient has called, and color-coded work streams, which I've added in very recently. So you can see any prescription for thiopurines will come my way. We have one of the nurses in beige, one of them in pink. Anything with obstruction, admission, flare has a box around it, because we might want to keep a closer eye on those patients. This was very easy to pull volume of calls, but we didn't have this data before. And this shows we were getting 281 calls per month through our advice line, which works out to be about 14 calls a week. A day. So obviously that's not spread evenly across that week, but it's certainly not the 30 calls a day that I was originally told. And these are the reasons for the call to the advice line. So I appreciate this is a busy slide, but I will talk you through it. We have 3,030 calls, And the top three categories constitute over 50% of the calls. IBD symptoms, completely appropriate. Medication supply and blood and stool test results was third. So this, we can ask the obvious question: can we use digital for, there's apps out there like Patient Knows Best, where patients can get their results in real time. They can even have access to their clinical documentation if there are those permissions, and that would give them information on their treatment plans. We then updates from the patient, call for specific team members, and requests for the patients to call the advice line. These are self-generated demand. This are calls that we bring upon the advice line ourselves. I'm not criticizing this. I think it is a good thing that we have patient empowerment. We have a close working relationship with them. It allows timely decision making, but it's just to recognize that we invite these calls onto our service. You can tell I'm a pharmacist because of all these green boxes, but I'd just like to focus on the second one there, medication supply, which constitute a lot of calls. So some of these were, for me, for thiopurine prescribing, some home care prescriptions. Some of them were requests for GPs to perhaps aid us with folate or iron supplementations, even corticosteroids if we haven't got a prescriber on that advice line for that day. But so much of this was about home care prescriptions and supply issues. And I do wonder whether our hospital home care teams can integrate more with our advice line service. In purple here, we have things related to appointments, so clinic appointments, blood test appointments, IV infusion appointments, requests for stool, POTS, and clinical documentation. Could this form business case for administration support? And then finally, I've got other inefficiencies where we can't determine the caller, or it's regarding non-IBD related symptoms. Perhaps we need to be more proactive in terms of telling people what the advice line is for, and just as importantly, what it's not for, and signposting people better to other resources. So in conclusion, this has cost nothing apart from my time. It's enhanced the governance. There's a clear audit trail of calls received and decisions made. It allows individualized patient-focused care. And you can see that top graph, those patients calling 10, 15, 20 times only constitute a small number of patients, but a huge number of calls onto this advice line. So that could allow targeted support to help these patients. It allows service monitoring and optimization. And my question for the room is, is there potential then to scale this up to an all Wales level, have comparison between other health boards, just to see how their data compares to this? And I'll finish there. Thank you very much.
David, thank you. That's a great bit of work. I'm sure will be much appreciated by your colleagues in the department. I think, Son, you had a question, didn't you?
Yeah, thank you for an excellent presentation. I was wondering, as the next steps, what seems to be the direction of travel in many such similar themes across is to develop, even though it sounds very strange to some of us, the chatbot type of interaction with patients, where depending on the theme, they're directed to a particular part of the service in a way, rather as the first interaction rather than directly on a call. And is that, do you think, going to be helpful?
I think there is a role for that in terms of appropriately triaging our patients to make sure that the calls we're receiving are the correct calls. But at the same time, I don't think anything can replace that human touch with our nurses and our people manning these advice lines. And so, yeah, I think it just needs to complement the service rather than, take over too much of it.
Yayan.
Thank you very much, Yayan Davis, Children's Gastroenterology. I have less to do with elective care of IBD, but I witness these specialist nurses when I'm on service weeks in UHW doing lots of the work you describe. Does the outcome from your system go onto the patient's Welsh Clinical Portal? Otherwise, I'd have concern that you've got a kind of parallel set of records going. Thank you.
Yeah, very good question. So no, it definitely doesn't replace that, because for transparency purposes, we've got to have those calls and those outcomes put on their electronic care record if it meets that threshold. Some of these calls relate to, oh, can I have a blood test appointment? Can I have a new stool pot sent out to me? That obviously doesn't need to go on their electronic record. So it definitely wouldn't take away from that really important, pertinent information that needs to go on there, which everyone needs to see. But we at the same time, we do need to capture all those other calls, which is still demand on our advice service, but yeah, not necessarily relevant to the wider MDT and other specialities.
Rod, really quickly, and I want to ask Claire something then, yeah.
What does your answer phone message say? Because whenever I ring the GP, it lists me a million things of what to do, who to call, when to call 999, have I got chest pain? So what have you thought about changing it to get better results?
Yeah, and I'll be honest, right? In the past, I've been guilty of trying to fix problems before I've collected the right data. We focused on trying to get as much data as we can, so we have the firmest platform to be able to make decisions on. We haven't quite got that far yet in terms of, redoing our automated advice line, or how do we signpost people? Yeah, so there are next steps.
One last thing, Claire, I'm taking the liberty to bring you in. Claire's our national IBD lead, and I just wondered, one of your last things was about having some sort of national thing. I just wondered whether you wanted to come back and any thoughts you had.
Yeah, I think this is a brilliant piece of work, and we'd be really interested to work on this with you. I know that the helpline is the bane of all IBD nurses' lives, isn't it? And one of our work streams is digital transformation, and including this using platforms like My Health Record that will take these calls and log it, because I take your point, it does need to be in the health records, and even in Cardiff, it's still on a piece of paper at the moment. Then somebody has to dictate a letter and upload it, which is ridiculous. So that's one of the work streams we're working on. And we're also looking at the other things on this. As you say, a lot of these can be filtered off by admin. A lot of them are about appointments, about prescriptions, and people calling unnecessarily. We always get IBD patients calling up with a sore toe or a UTI that they need to be redirected to the GP. So I think this piece of work on what you're doing is absolutely brilliant, and we'd like to work nationally on a Once for Wales approach. So we are asking for DTIV support, which is digital transformation, and it'd be really helpful to feed this into that.
Just to add to that, I am liaising with performance and improvement, and we are working on a service level dashboard. So it cuts all the patient identifiable data, all the staff names and everything. So you've just got a service monitoring demand dashboard. So yeah, that could be something that could be useful as well to upscale.
Thank you. So I'd have to cut you off there. Thank you ever so much. Thank you.
We now have the presentations in the medical student category, and our first presenter is Zakaria Chowdhury. And the title of the presentation is Optimizing the Utility of CT-Detected Esophageal Abnormalities in Predicting Malignancy, a retrospective review. Thank you.
Thank you. Good afternoon, everybody. My name is Zakaria. I'm a medical student. Before I begin, I'd like to give a quick thank you to everybody who's already presented. Today, my presentation will be in regards to CT-directed endoscopies and their relation to malignancy. And this is a topic which intertwines multiple different specialties, from radiology and oncology to, of course, gastroenterology. So I'd like to start with a quick story. Here we've got Bob. Bob is going to be our patient for today. Bob has a consultation with his radiologist, and his radiologist tells him that unfortunately they see a little bit of esophageal thickening on his CT. As they're quite concerned, they decide to refer Bob for an endoscopy. Bob's story alone is fine. However, when you consider that there's almost 20,000 patients in Bob's shoes, this can cause quite a lot of congestion, hence quite a big problem. Now, before I tell you about the research project itself, I think it's quite important to understand the why behind it. So if we look at these statistics, we can see that approximately 5,000 patients who have a endoscopy requested are not being delivered. And if we scope in a bit further into gastroscopy, we can see that almost 700 patients are not having their request delivered. So this presents us with a diagnostic dilemma. Incidental esophageal abnormalities often triggers incidental esophageal abnormality on CT often triggers a urgent 2-week referral. However, this often leads to quite a lot of congestion. So the study's aim: do CT-detected esophageal abnormalities correlate strongly with malignancy? And very importantly, can we refine the referral criteria? So now we've understood the why. We understand that the endoscopic demand and the return is imbalanced. And we understood the study's aim, where we look to refine the criteria. We can look further into the methodology itself. So we looked into 280 patient pathways, and we looked into specifically patients whose CT scans reported suspicious esophageal abnormalities. We looked at multiple different factors, from demography to OGD abnormalities and clinical markers. We then use SPSS IBS software for statistical analysis. So what did our results find? Here, I'd like to pose a question to everyone in the room. What percentage of patients do you think with a CT reported abnormality were ultimately diagnosed with a malignancy? Do you have any suggestions? 5%, 5%. Okay, so I could tell I'm in a room with a lot of gastroenterologists, because I asked this to medical students and I was getting 60% and 80%. So that's you guys are a lot closer. So the answer is less than 4.5% of CT reported abnormalities were ultimately diagnosed with malignancies. So for context, that's approximately every 24, 23 scopes, resulting in one malignancy detected. This also suggests, proves that 268 patients out of 280 did not have a malignancy on OGD. However, it's important to note that in cases where CT showed esophageal abnormality, 57% of patients did have some sort of abnormality, be it malignant or benign. Okay, so furthermore, what can we look to do to refine this pathway? Two specific clinical markers that we looked at was anemia and dysphagia. With anemia, there was a strong significant value, as 75% of cancer cases also had anemia. When we look at dysphagia, 25% of cancer cases had dysphagia. This suggests to us that both dysphagia and anemia can be strong predictors for malignancy in the future. If I direct your attention to the graph on the board, you can see that a strong percentage of cancers have a strong percentage of patients with anemia with those under the category of cancer having cancer. Now, what else did we find? We also looked at reporting language. Now, communication in everyday life is pivotal and a big part of our lives. If I ask you all to look to your left and look to your right, we're all different clinicians with different ways of communication. And this translates directly into our reporting style. We looked at when OGDs were advised against considered, and we found that those where OGD was advised had a stronger rate of cancer detection. One positive finding we've also found was that patients in whom were eventually cancer was detected, they had a shorter time from CT to OGD of approximately 2 weeks. So ultimately, what is the clinical relevance? There's a very low yield of current referral practice. Anemia is the strongest predictor and could drive prioritization in the future. And reporting language does matter a lot, and it's not just a matter of semantics, but can also give us a guide into a clinician's suspicion on a cancer, whether or not a cancer is present. So what does this mean? Do we stop referring everybody? Well, CT scans, we can say, does not always correlate to a cancer. However, it's important to note that endoscopies are still finding a lot of positive results in terms of benign and malignant pathology. Ultimately, if we want to improve risk stratification, we may need to involve the likes of CT and clinical markers to guide us. This is in the hopes that eventually we can reduce endoscopic demand without sacrificing cancer detection. So ultimately, just to reflect on the project itself, a couple of strengths include the search terms that we use, as well as the duration being from 2022 to 2025. However, in terms of the weaknesses, we could look to increase the sample size and also include other imaging modalities. Now, in terms of future steps, we could look to increase the search terms and the sample size, but also we can look to aim to present this data at gastroradiology quality and safety meetings. So just with a closing thought, with the refined criteria, can we look to ensure that our patients get the right test at the right time, maximizing diagnostic yield and the efficiency in the NHS? I'd just like to give a sincere thank you to Dr. Hassan and Dr. Ellis Owens for the guidance and support in the project. Thank you very much for your time.
Thank you very much. Can I take Chair's prerogative and ask you the first question? I know there are colleagues here in the first row who would also like, while the mic comes to them, if we can have some mics in the first row, please. We already use anemia and dysphagia as clinical indicators. What were the indications? Because Bob was lucky he got a consultation with his radiologist, but I don't know how he managed that, because generally people can't do that. So what were the indications that led to the initial CT?
So for different patients, it was different things. So it ranged from a range of things from weight loss to lymphadenopathy to anemia and so on. So it was more on a patient-to-patient basis, and we had to scope through those patient pathways.
CT scans, point exposure, and should be investigated in hospital so that persons should patients have not specifics. A lot of them came from the regional diagnostic centres.
I think the real value of these cohorts seems to be in examining the outcomes in terms of whether incidental findings led to different stage cancers, etc. But anyway, let's go to our questions.
Thank you. It was really wonderful presentation.
Thank you.
I think one of the important things to note is the outcome, even though it seems like a very low yield, it's better than what we currently do for USC referral based on dyspepsia guideline. So if 50% we are having some finding, that means I think it still is a very useful test. So we shouldn't really undermine the value of doing endoscopy in this CT guided patient.
Yeah, I think that's a very poignant point. I think the current guidelines for the NICE guideline 12 suggest that there's a threshold of 3%. And although it's higher, it's still quite a large contributing factor to why there's such a high demand of endoscopy. And I think it's really important to raise awareness, be it through these radiology and gastro meetings. As ultimately, the more exposure they get, the more raising awareness, the more likely clinicians are to pick up these cancers in the future.
Thank you. Hamza?
Yeah, I have a specific question for the godfather of cytospond in Wales, Dr. Hassan. So, as he said, just like if we has to scope every patient who have, I think, esophageal actually thickening, this will put huge pressure on endoscopy actually in Wales. Did you think that cytospond could just bridge, just like the gap of the surface, like to just like use it as whether this patient genuinely need endoscopy or no? Yeah, capsule and cytospond, yeah.
Patients who've got thickening, I guess the question is though what that thickening is, and you'd be worried that there may be a more malignant lesion or something that might get stuck. So it'd be contraindicated.
Thank you.
Sorry, Kath, we're going to have to, you can ask them at coffee time. In the interest of time, we'll move on now. Thank you.
Right, our final presentation of this session is from Sarah Batal. So Sarah's going to present to us on another Puget-related presentation. So optimizing clinical practice to improve dysplasia detection and reducing Puget rates. Sarah.
Hello, everyone. My name is Sarah Batal. I'm a fourth-year medical student. I undertook this project with Dr. Haboubi during my SSC last year. So I'm just going to start with the title. It's optimizing clinical practice to improve dysplasia detection and reduce Puget rate. So as we have mentioned earlier, Puget is post upper GI cancer has been misdiagnosed within 3 to 6 months, 3 to 36 months after endoscopy has been done. So there is possible reasons that the Puget rates are increasing, can be missed lesions, can be inadequate biopsies that have been taken, or it could be because we're doing not as optimal endoscopy surveillance as we should be. So today we're going to be focusing on the endoscopy surveillance. So one of the learning objectives that we focused on was whether to see the key procedural factors and whether to see if these had an effect on the endoscopy. So we wanted to see if we can assess the impact of endoscopy quality in esophageal dysplasia detection and then also improving early detection and minimizing the progression to esophageal cancer. So we know that Barrett esophagus is one of the precursors to adenocarcinoma, which is the main type of esophageal cancer in the UK. So there is a recent paper that's been published from Action Against Heartburn. It says that the UK oesophageal cancer is higher than most of Europe. So the highest rating is in Netherlands, which is 14.9 case. It's been 14.9 cases per 100,000 people. And the UK is not that far off. It's also 14.2 cases of esophageal cancer per 1,100,000 people. In comparison to Italy, which is 3.5, and in Spain, which is 4.4, and 7 approximately in Germany and in France. So there is 9,200 new cases being diagnosed annually, and we have poor 5-year survival rates of esophageal cancer around only 17%. So what we wanted to do is that we did a retrospective analysis from June 2023 to December 2023 in Landock Hospital, analyzing 192 patients. And the procedural factors that I wanted to analyze included sedation type. So we looked at midazolam against use of fentanyl. We also looked at using Prague rating system, so like using the maximal extent, rating the maximum extent of the metaplasia, and then also the circumferential extent of the metaplasia. Then we also looked at the acetic acid use. And then we looked at the use of MBI, if they have used as MBI with acetic system. And we also looked at Seattle biopsy. So most of you guys would know, but Seattle biopsy is taking 4 quadrant biopsies every 2 centimeters of the Barrett segment. And then we also looked at the Paris lesion characterization, if they also used that to describe the lesions. And finally, we looked at the patient comfort and compliance. So the results. So the results, first of all, we looked at the type of sedation. So we looked if midazolam effect against fentanyl, like I said before. So we found that there was high and strong correlation between using high dose of midazolam and detecting abnormal lesions, whereas fentanyl had a less pronounced effect. There's also some research papers that also suggest that the use of combination of midazolam and fentanyl can also help in detect dysplasia, but we did not find that in our research. But we found that we had a significant trends toward using the combination of both. And then we looked at the patient comfort and the quality of imaging. So in short term, if the patient is comfortable, you'll have a better quality of imaging. We found a significant value of 0.001. And then we also looked at acetic acid use and its effect on visible abnormality and dysplasia. So we found that if we use acetic acid, and the use of loss of acetic whitening effect, there was a significant correlation between that and the and detecting visible abnormalities, and also it helps the endoscopist suspect dysplasia. And then we also looked at the use of MBI with acetic acid as well. And there was also a strong correlation with that. So we had a significant value of less than 0.01. So if you use MBI and acetic acid, there is an enhanced dysplasia detection. And then finally, in experts' hands, we found that Seattle protocol did not confer additional benefit over targeted biopsies for dysplasia detection. And in conclusion, the finding of the study highlight that the higher doses of midazolam improve dysplasia detection, that if we use acetic acid, we can also enhance the lesion visibility. And then if we also ensure the patient is comfortable, we can also have a higher quality imaging. Pugic data suggests that the use of midazolam and fentanyl can also improve detection, but we did not see that in our finding. And then Seattle protocol may aid in dysplasia detection. And then MBI and acetic acid appears to be more beneficial than Seattle protocol. Yeah, that's it. Thank you.
Thank you, sir. That was absolutely dead on time to the second, actually. So well done. Yeah. Questions, please, for Sarah. I just wondered whether one thing here was there a compound effect? I wonder if some operators did all those things and some of them did none at all. Is it kind of operator dependent as well as all the different components you've mentioned there? Because I reckon there'll be individuals who use fentanyl, use midazolam, use acetic acid, use NBI, blah, 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 blah. And then there'll be people who don't. So I wondered whether just taking little components out gives you the whole picture. I think Hassan's going to help.
Do you want me to answer that? Or do you Yeah, I mean, we have a challenge, like many places have challenges. So we do have some dedicated Barrett's endoscopists. We all know who they are in Cardiff. And then we do also use some insourcing, and some Barrett's has trickled onto those. I suspect that's probably where we've seen some of that significance. So it's a shame we didn't actually look to compare pure insourcing versus our in-house endoscopists. We missed a trick on that, but I suspect that probably also would have reached significance.
It sounds like a future project for you there, Hassan. Yeah. Yeah.
Just wondered along the same lines, because what we're talking about there is univariable and multivariable analysis, but would you be able to draw very firm conclusions on that sample size? Or is it more like a signal that needs further?
Yeah, I think you're right. I mean, at the end of the day, we're presenting this because I think there's some really important take-home messages for us all in terms of dysplasia detection and some of the things that we can use. I'm not sure we're necessarily reinventing the wheel here. We know that if you use all of these adjuncts, you're more likely to detect dysplasia, whether it's a dedicated Barrett's endoscopist or anyone else. They're all there as helpful tools, really. So I think it's just to reinforce that point. There's a bit more data that we're working on. If Sarah's willing to come back and go through some of those extra bits of data and maybe present it to you all next year on some of those other areas.
Yes, I would love that.
I just look quickly around the room. If not, Sarah, thank you very much.
Thank you very much.